take over and introduce your panel and ask them to come over stage, please.
So, an important announcement. I mean, we are running the resident training program, the lectures in Hall B. So, I would request all the residents to please, if they can move to Hall B for the lectures. Simultaneously, we have also arranged for the hands-on training, which will be done in between the lectures. So, the residents, they can move to Hall B. Thank you.
Thank you very much. Shall I invite my board members of the next session, Dr. Tumour, medical oncologist from UK, here in the field. Ravindra Sabnis requires no introduction. Adil Batra is again in the medical oncology. Uttam Mite, Anup Kumar, young dynamic, again for urologist, no introduction is required. Uttam is from PGI, Anup is from Saptajang. Rohit Sethi, Sudeep Das, again from urology. Then Moses Arun Singh, radiation oncologist. So this is a renal tumor board. I am not discussing something like a case discussion, but I'll just catch crucial points. Thanks to this trio, Amit Ghosji and Tarun for excellent meeting. Scientific coordinator Ravi, who is the marshal of this event, he has given the instruction that we should drive in 2-3 points at least and should stick on to time. I will try to do justice to what he told. So these are my board members and welcome to all. So the most important point I want to drive in is the change that has happened recently in the classification of RCC. 10 years, 20 years back, we used to have every 12 years some change, but now frequently in the last 6 years it has changed, and probably it will be coming more frequently in the coming days because of the new points which is added because of the extensive evaluation, molecular and genetic. So you can see that this is mainly the clear cell, papillary, chromophobe, then collecting that, then a chunk of lot of different variety of tumors based on molecular markers. This is the current classification. So it's totally confusing. We have to learn the renal tumor again. That is the situation now. So with these remarks, I will go to my first case. This patient was recently 2 months back, he came to me, 70-year-old young chap doing engineering, presented with hematuria. Creatinine was normal, ultrasound was done for hematuria, renal mass, and an MRI was taken. So MRI showed 2.4 centimeter renal lesion in the posterior aspect. These are the lesions. You can see the lesions. Again, in T2 weighted, it is bright, and there is enhancement, and according to them, it is compressing the calyceal system with probably involvement of the sinus fat. And metastatic workup is negative. So putting it short, it is a young guy, 17-year-old, having a posterior, completely intrarenal, probably sinus invading or at least sinus fat invading tumor. So the concerns he has is, sir, are you sure there is a tumor? Should we do a biopsy? Second, my child is studying. I want to go for avoid a treatment if possible, as at least for till his course is over, and active surveillance can be just postponed for years. And if you are operating, are we going to lose the kidney? These are the concerns. So I'll just ask my panel and audience. So first thing is about biopsy. Dr. Sudeep Das and Rohit, do you go for biopsy? And this particular case, should we go for biopsy because it's a small tumor? They are very much concerned. Should we go for a biopsy?
So since he is very young and tumor is also small, less than 3 centimeter. But generally, traditionally we do biopsies for whom we want to keep on active surveillance. But 17-year-old boy, we need to lifelong. We'll have to keep him on active surveillance. That may be difficult. But probably since he is young and tumor is quite central, probably we can do a biopsy and then tell that what it is, and then probably go from there.
Any opinion from rest of the panel or from the audience? Should we do for a biopsy for a young chap? Is going to change the management in any way? Any from the rest of?
I think the patient is symptomatic right now.
Yeah, hematuria, sir.
I don't think that we have to take out this tumor.
Okay.
We cannot go for active surveillance in this particular patient. And it's a mid-polar going into sinus fat. So this keep on causing hematuria on and on. So I think this patient, there is no need for biopsy. We can go ahead for
Directly go for it. Okay. Any opinion from the audience? Yes.
We are seeing many molecular-based kind of tumors or genetic tumors like translocation XP11.2, eosinophilic, solid cystic tumors. So before we embark on any sort of treatment, I think the biopsy is must considering his age.
So will you change the management? Like, will you avoid a partial if the biopsy is inconclusive or showing some changes? Or will it change from partial to radical? Or will it change to a active surveillance of conservative like SBRT?
See, the choice you have is, as you mentioned, either you want to do sort of radiotherapy or observation, active surveillance, so-called, or something like partial or radical. So before you embark on anything, I think we should...
A biopsy is required according to you.
Yeah. I think because he has got a hematuria and imaging wise it is infiltrating the sinus fat, maybe I will not opt for a biopsy.
Okay. So this is yeah, sir. Anand sir.
He is a 17-year-old. In younger the patient, these tumors are not good. So I would like to take it out, have proper histopathology and ISC to know how we are going to deal. It is 17-year-old symptomatic. So I won't even time wasting the biopsy.
Yeah, okay. Straight away you want to go for surgery?
My question is this, that considering his age and possibility of having a variation of the clear cell RCC, which may not be the appropriate treatment in partial nephrectomy may not be the
No, in partial also we will get the biopsy.
In that condition, I think the biopsy will be able to guide us in a proper manner and we can do a
you are
radical nephrectomy.
So difference of, yeah.
So again, I can speak from a UK perspective on this one. I think we would absolutely biopsy a 17-year-old. The chances of there being histology which is not clear cell is significant. If you look at the data which we looked at from our British Association national audit on this, in over 40% of people under the age of 40, the post-operative specimen shows a tumor which is not a clear cell renal cell carcinoma. In this young kid, it could be a spectrum of disease. He might have translocation tumor, it might be collecting ducts tumor which would go on to have chemotherapy. It might be an oncocytoma which does not need treatment. So in our practice, I think biopsy would be mandatory.
Biopsy, okay.
Ginil, Ginil.
Yes, sir.
You know, this is not a common age to get a tumor. And he's going to have massive hematuria.
Yeah.
You know, I have to, other kidneys normal. I would confirm, before I do biopsy, I'll do a CT angiography. See why he had a hematuria, what is the pattern look like, what is the collecting system look like, what arterial supply look like, and then a biopsy. Because here you are building up the case for a radical nephrectomy. And then looking at the father's questions, all this thing, you need a definite answer. There is no other alternative but do this. Or can I do a partial?
Okay. So CT was done from outside, I couldn't produce it, but it was just similar picture, that is why I haven't done it. It was just doubtful of invading the sinus. Apart from there is no other points, and I felt that amenable to partial, and so we were discussing in that line. Sir, please.
Just apart from biopsy, cytology I would do, and then I would look for the family history because there got to be
Yeah.
something genetic in there.
Yeah, exactly, sir. Family history, there was no family history of any tumors, either related to tumor or syndromes. Then cytology, actually, we haven't done during that time, but I agree with you, cytology is also required because TCC can be. Okay. So we'll proceed with SBRT. What is your opinion about, because the patient is keen on active surveillance, will you go for SBRT for a small lesion at this age? Because all our data is on old age and compromised patients. This age, is the data mature enough to suggest something like that?
I don't think it is a case for SBRT at all.
Okay, so Subnisar is against SBRT and Moses?
Yeah, I mean, probably this is not
Okay,
the ideal.
not a case of agreed. Okay. Observation, Dr. Simon, will you go for observation in this patient, or you go, and Atul? Any role for active surveillance again?
As the third radonc here, I also wouldn't do SBRT. So I think you wouldn't observe something in a 17-year-old unless you know what it is.
Okay.
And the only reason you'd observe it then if it's something that doesn't need treating.
Okay, so no role for observation, that is fine. So, Uttam and Anu, regarding the surgery, will you go for partial or radical? This is a sinus tumor and is a young child, we don't know the pathology and they are concerned about radical. At the same time, partial is going to be a bit difficult, challenging posterior sinus invading in completely intrarenal. So, Uttam and Anu, your approach?
I would prefer to go for a radical nephrectomy rather than
Okay.
partial nephrectomy.
Okay.
So it's not a question of technical feasibility. See the imaging, it shows sinus fat.
Sinus
infiltration,
fat, yeah.
and patient has got a hematuria. That means there
Okay.
is most likely involvement of the PCS also. So in such situations, I would definitely other kidney is normal. So I would like to go for a radical.
And then naturally comes another question. In T3, can you justify partial? Because there is in the European urology guideline, they say that there is at least there is some meta-analysis of at least one paper of more than 1,200 paper data pool, telling that T3 is justifiable, like equal cancer-related outcome.
Only thing the way I can justify partial nephrectomy because the patient is very young. I am thinking of a
that is
genetic
the pathology
tumor.
is the
Chances
concern.
of recurrence is very high. So maybe we try to
Radical.
save the nephron as much as possible.
Yeah, Anu?
So my plan will be, I will counsel the patient that I will go for robotic partial, but it will be difficult procedure. There are chances of conversion to radical nephrectomy. But we have done these cases before, and we were able to do it, and there are a lot of literature to support that.
And
Ginil,
So therefore, I think for this kind of tumors going to sinus fat, partials are feasible, and they have good oncological outcomes.
Subnisar.
see, this CT scan report infiltrating sinus fat quite often
No, it is
little
actually
bit dicey.
sinus,
Is quite dicey. Sometimes it is a false positive, false
False
negative.
positive can occur.
And sinus fat, it actually appears a very round capsulated tumor. Sinus may just be approached, but may not be infiltrated. So there are a lot of things in that. And I feel I agree with him that in that situation, whether to do partial or radical, biopsy may be. Biopsy is not for deciding whether a treatment is required or not. Treatment definitely is required. But what sort of a treatment? If on biopsy, you know, there is a variant histology, it is aggressive tumor, sarcomatoid. There are so many classifications have completely changed. In that case, we can decide whether really to go for conservative sort of a partial nephrectomy or go for the radical nephrectomy.
Yeah, this is a good point, sir. Well taken.
Discussing about the tumor size and the sinus fat. What about the hematuria and the amorphous clots? How do we explain that in this sort of a tumor?
Yeah, actually sinus fat, maybe a calyceal infiltration is there, who knows, we will find it later. That is what I was telling in sinus fat invasion. There was a meta-analysis telling that in actual renal tumor there is a comparable outcome when they pulled the data. So T3 now we have got evidence to say that if you have done a proper without margin positivity, that is curative.
But calyx infiltration and the sinus fat is completely different. If there is a calyx infiltration, if there is a peripheral tumor, that's not a contraindication for partial nephrectomy. It is the sinus fat which actually has the problem.
So is a predictor for metastasis? Yes.
Both the gentlemen dismiss SBRT out of hand. Why? I want your reasons. Why? Because if there is a possibility that when you do surgery, it may turn out to be a radical surgery and you're going to have to remove the kidney. So why would you not consider something which has a good percentage of curage and preserving the kidney, with the nephrectomy always as an ulterior objective? So I want to know, why was it both of you dismissed SBRT out of hand?
Yeah, so the biggest problem of SBRT is that if you don't do biopsy, you have no idea what exactly is the histology.
I think biopsy should have been done anyways.
So what sort of histology it is?
Yes.
And all said and done, SBRT is evolving. It is not yet established. There are still not, as in the previous lecture it was said, that there are no randomized trial, whether which is superior, whether it is equal. It is only that SBRT has shown that there is a promising result. But unless and until it actually clarifies in comparison to partial nephrectomy or the surgical management, it may not be appropriate, especially in a patient of this age group.
So what we can do, data is not good enough to suggest it to the entire population. Probably in our, we cannot do. As an alternative for active surveillance, we can go for SBRT at present. So we did a retro partial for this patient, and as we were discussing, we can see that we on ultrasound we had a doubt or perioperative ultrasound. The calyx was open. This is a tumor you can see inside, and this is a small tumor but infiltrating the calyceal system. At this point, my concerns are, should I go for a radical nephrectomy at this point, because I don't have a tumor board to discuss on table. At least I can retrospectively I can discuss now. Should I go for a radical at this point?
Would you do frozen in the suspicious areas?
No, sir, because I didn't want to touch the tumor and disperse it. So I just left it. I know that there is a tumor. I have to either take it out or do a radical. So which one you prefer? Dr. Uttam or Sabnis or Arturi?
Get your questions.
No. Should I go for radical nephrectomy at this point when I saw the calyceal system involved? As you were suggesting radical nephrectomy, I'll ask Anup whether you will go for partial after you discuss. You will go for radical at this point?
Definitely I will go for radical.
So Anup, will you proceed with the partial at this point?
So the tumor going into calyx is not a contraindication of partial. You can very easily excise the part of the PCS. Only contraindication will be if the major part of the pelvis is involved. And you have nothing PCS left to drain the kidney. That is the only indication, I think, where I will not go for partial. But I think this case you can go ahead, remove the part of the calyx involved, get a good margin, and can still do the partial.
So we did exactly the same thing. We excised with a good margin of, because we could see it properly, we excised the calyceal system with a good margin without touching the tumor, without, yes, sir.
When you saw this picture, how are you sure that you're not dealing with TCC? When you saw this, because you're at this
that
point,
is actually a difficult question.
You would actually first ask yourself, what exactly is the problem? RCC, TCC?
Yeah, because from the CT, I initially thought there is a tumor that is coming from the, mainly from the cortex. That is why I just proceed with. That is actually one concern. So should I go again for, do you think there is a TCC? Sir, Prakardas or Kushit sir? At this point, what should I do? I don't have a tumor board on table.
Yeah, Prokar doesn't want to, he wants me to use my shoulder for the gun, but I'm okay, you know, that's what he's done all his life. So, yeah, what his question is that, what about the biopsy? Now you have everything open. Yeah. So you have to make a decision. We kind of, the board has left because you didn't make the decision earlier. Now you're on the table and you don't know what it is. Yeah. Why not send a frozen?
Okay. Unfortunately, I didn't do it on table and I just excised. But that is a good option. But I was concerned about the seeding by touching the tumor. Is it a genuine concern, or should I just...
You are already, this ship has sailed. The tumor is open.
Yeah. So we excise the tumor, and at this point you put the stent, routinely you put stent, any of the urologists, Sabnisar or Uttam or Anup, do you put the stent or just close it after partial?
Just close it, not necessarily.
Just close it, okay. Yeah. Anup say? I also did the same thing, just closed it. So the biopsy came as papillary RCC, 2.5 centimeter, calyceal infiltration, and it is a T3A tumor. Again, how to proceed? Sir, Dr. Simon, are you happy about the papillary RCC, just a papillary RCC biopsy?
Well, I'd normally be talking to my medical oncology colleagues as a RADOC, and I don't think you're happy with any RCC diagnosis in a 17-year-old. I'm not aware, though, that there's much we can do, evidence-based in this setting, other than watch very closely. And as we were saying earlier, the other thing we do need to do is make sure, even if there's no family history, that we've done a genetic panel on this chap, because he's a 17-year-old with a Pooleri RCC. Do we have a med-onc on the panel? Hi.
So the data for adjuvant comes from the keynote trial, but that included all clear cell RCC, and that was T2 and above and T1 grade 4. So this is papillary, we don't have data, and that also the data for OS is still getting mature, we don't know. But I would be keen to discuss that with knowing that papillary RCC in metastatic setting does respond in a similar way to clear cells. And now in all the subset analysis and all phase 2 trials, we've seen that the responses are almost similar, and it adds on to the VEGF. VEGF, we surely know it does not add to the overall survival benefit. It does delays the progression to a metastatic disease. So VEGF, no. As a guideline, level 1 evidence, nothing that we can do. 17-year-old, ET3A, one-on-one discussion, pembrolizumab, 1 year, adds to around 8 to 10 lakhs. Lots to discuss, but no level 1 evidence, one-on-one discussion.
So non-clear, you don't want to think of an adjuvant at present based on...
it would be based on a case-to-case basis, like some histologies, TFE, we know it doesn't respond much to immunotherapy, it is more of VEGF that works there. So had it been that, I would have been a little, or it was a T1 kind of a small tumor now that it's going into there. So probably I would discuss, it's a tricky situation, he is 17. It's a more of desperation that comes in, data, it's not there.
So about the pathology, one more thing is...
Can I answer that question? Pathology. So because it's a papillary tumor in a young boy, pathologists have given the diagnosis based on architecture only. So I would like to go for a cytogenetic study and discuss with the pathologist whether we are really dealing with a papillary, because it's a papillary architecture.
The papillary type 1, type 2 is completely gone. Now everything is based on the molecular pathology. And this type 2 is completely disintegrated into different things based on molecular, and this is the molecular genetic study, NGS we did, and it is TFE3, and TF3 actually is slightly different from RCC. So young adolescent individual, when there is RCC, there can be a lot of confusion, and we are learning that this around 50% can be early translocation. Now the term is again changed. This TFE3 rearranged RCC according to 22 classification, and 50% can have lymph node metastasis in this group according to recent data from the child oncology group. So young patient maybe it is aggressive, but again he had a urine leak at 2 weeks. Anup, is a retroperitoneoscopic surgery, urine leak.
So these kind of leaks are very unusual normally because we are closing it with a very good suturing. If it happens, as you did rightly, just put a stent, it will stop.
Okay, stent and it healed. So I'll just go through a quick bridging of this case. 44-year-old gentleman, chest pain, evaluated, chest X-ray had some small doubtful hazy shadow. On evaluation found to have this lesion, solitary chest lesion, and kidney had a less than 3 centimeter lesion. So Simon Hughes, this is a patient with solitary kidney renal rib metastasis plus a renal mass. And what will be the best option? Should we go for a TKI followed by surgery, or just proceed with partial nephrectomy and resection of the solitary mets, or TKI immunotherapy without surgery is a metastatic? What will be the best option for you for this patient? Solitary met? Atul and Simon.
So if it's resectable, then radical nephrectomy, resection of metastasis, and then 1 year of pembrolizumab would be the treatment of choice.
Okay. So you want to treat as an adjuvant even though it's a MS2?
M1 NED was a subset that was included in the keynote trial, although it represented 10% of the patients, but M1 NED So where it was metastatic to begin with, but you removed all the metastasis.
Okay.
Within 1 year of the primary surgery were also included in that trial. In fact, the subgroup analysis did show that this was the subpopulation that probably showed the maximum benefit as well. So if it's resectable, that gives him a curative chance, right? So surgery and then 1 year pembrolizumab would be my choice.
So again, is a bit of a tricky situation. I had 38-year-old post-transplant patient after more than 12 years, developed a renal mass. He is on immunosuppression. This is the renal mass. On the transplanted kidney, solitary kidney, it is almost reaching to sinus. So I'll just finish with this case. Options we have: biopsy, graft nephrectomy, and say the patient to have again a biopsy transplant later, or go for SBRT, cryo or RFA, which or be a ablation treatment, or a partial nephrectomy. So from any of my board members, biopsy is required or not?
I think this case straight away requires nephrectomy and
Nephrectomy and
immunosuppression, because he's on immunosuppression.
Okay.
And any biopsy or anything is going to complicate the matter.
Okay. So don't want a biopsy, a nephrectomy, and but the patient has got financial concern. That is another story. But thing is, graft nephrectomy and transplant. Any other opinion about from the audience?
Done. And turns out to be lymphoma, which is common condition in post-transplant. Where do we stand?
Okay. So you prefer biopsy. Any other opinion? Just, yeah, biopsy, we did a biopsy and it is a clear cell carcinoma. Now, what to do? So, we did a partial for this patient and we could come out with a clear margin. Negative creatinine is at 1.2. So, what I want to say is, even though it can be difficult, sometimes we'll be able to get away with that, and always is a good thing to try for a partial, especially in this scenario. So what I want to...
Ginil, what sort of immunosuppression change you made after partial nephrectomy?
So actually they just on the same day itself, they started the same immunosuppression. There was no change in the immunosuppression tacrolimus because creatinine was perfectly normal.
Yeah, Dr. Ginil, I have a question. Regarding the first case, if you would have done the biopsy pre-operatively and you are having a diagnosis of papillary RCC, have you gone for the partial nephrectomy in that condition also, or you would have changed your decision to radical nephrectomy?
I would have counseled for a radical nephrectomy because adult translocation RCC has got a worse prognosis.
Second question, the classical teaching is this in all pediatric and adolescent RCC, we should always offer a full RP-LND also.
Yeah,
so
that is one thing I wanted to highlight.
Have you done it or not? And
no, I haven't done because there was no radiological or clinically enlarged lymph node, but I understand that this patient can have more lymph node involvement up to 25%.
What you are saying, it is for the adult RCC, but in classical pediatric and adolescent RCC, even though if there is no radiologically positive lymph node, you are
supposed to have a lymph node dissection. I agree with you.
Condition.
Agree with you. That is one more point I wanted to highlight. So these are the points I wanted to highlight. On these young patients and bilateral, we have to have a germline and somatic mutation. Papillary RCC classification is changed on molecular subtyping. Adolescent tumor recurs lymph node dissection, as Samir has just told. Translocate RCC is aggressive in young adults. Biopsy, whether it is needed, is a question we have to answer. And partial nephrectomy, non-clear RCC, were to go aggressive is another question we have to find an answer. Partial nephrectomy should be considered in solitary kidney to be done by somebody who is professional in that. Thank you very much.
Can I make a comment about the immunosuppression? This is a recommendation in such patient. You have to change to the sirolimus and everolimus and may stop the MMF, which you
MMF, okay. So we usually keep it in nephrology. I'm not sure whether it is done, sir.
Just a quick comment. As I mentioned in the first presentation, when you showed the first case, I did say it's a translocation XP 11.2. We have a series of 75 patients which are almost getting published now. And experience, I'm telling you, the younger patients, you do have two extremes. There are patients who do extremely well. They do not need, I mean, we have been following them for the last almost 15 years. And they have been all done genetic testing, molecular testing and everything. And there is also a subclass which they do not do very well, come what may be. As far as lymph node dissection is concerned, we were sort of impressed with doing sort of a retroperitoneal lymph node dissection, but we hardly found anybody, even with lymph node dissections, extensive lymph node seen on sort of CT, MRI, we haven't found any metastasis on those. Just the findings I'm sharing with our public.
Translocation again now is TFE3 and TFEB mutation, they are genetically different. So outcome also can be different cancer. Thank you very much for all the faculty and thanks for giving me this talk. Thank you very much.
Thank you, Dr. Ginil, for this kickstarting this program in a very wonderful way and very, very nice discussion from all the panelists as well. Thank you very much.